Good afternoon and welcome. I'm Dr. Richard Barron, President and CEO of the American Board of Internal Medicine and the ABIM Foundation. And I want to welcome you and thank you for your interest in learning more about our Building Trust initiative, which we are launching publicly today. The number of you who are interested in this has really been deeply encouraging, and we look forward to carrying on a broad conversation about trust. Why is our foundation interested in trust? Why are we having this event? Well, we know that there has been a broad decline in trust across all institutions, across confidence in expertise, and that we believe that this decline in trust also has a significant impact in healthcare. Because in healthcare, what do we really do in healthcare? We offer expertise in service of patients with needs. And many of us in healthcare, we have a scientific background, it's scientific medicine, and we are trained to believe that it's our method that gives us credibility. It's our method that causes patients to have faith in what we're going to recommend and what we offer. But what we've discovered with a general assault on facts, expertise, it has undermined trust in lots of institutions. And we realize that healthcare institutions need to think differently about trust. Trust could be, perhaps must be, a core strategic priority in the way healthcare organizations create relationships with the patients they serve. Now, that's an unfamiliar place for us to be. We're all used to talking about our expertise. Our foundation's mission is improving healthcare by strengthening medical professionalism. And we think trust is foundational to professionalism, and professional behavior on the part of clinicians in the healthcare system is foundational to trust. The pandemic has been a stress test for the healthcare system. It's a stress test that there have been some remarkable successes. The creation of a vaccine in under a year is truly astonishing. But there have been some glaring failures. We've seen hugely disparate outcomes in Black and brown populations, and we know that those populations see that as evidence today that maybe healthcare institutions are not that trustworthy. We've also seen an enormous amount of stress and strain in relationship between clinicians and their patients, between clinicians and the healthcare delivery systems in which they work. And as I say, it was a stress test, and it was a stress test that some institutions did well and some not so well. Healthcare institutions confronting the pandemic had to face everything from initially terrifying financial results in the second quarter of last year when revenue fell off a cliff. How did they respond to that? Shortages of PPE, how did they respond to that? Challenges in allocating ICU beds. This created an enormous set of stresses and strains on the system and exacerbated some fissures of trust. So our foundation set out to learn more about how trust was experienced and thought about during the pandemic, how the pandemic might have changed it, and the implications that might have going forward. We engaged NORC, National Opinion Research Center, and they did a survey, and you're going to hear full details of that survey discussed by my collaborators from NORC, Caroline Pearson and Krista Fields. You're also going to hear a broader discussion of the Building Trust initiative, of the Foundation's strategic approach to how to engage healthcare more broadly on focusing on the importance of trust from my colleague Daniel Wolfson, Executive Vice President of the Foundation. And you're going to hear a panel moderated by Foundation Chair Jackie Jedd, which will speak with a number of people active in healthcare and a patient and consumer advocate active in healthcare who have been thinking a lot about trust, working on trust, and making trust core to the work that they do. So thanks for your time this afternoon. And it's my privilege now to turn it over to Caroline Pearson and Krista Fields from NORC to present the findings from their survey. Thanks for your attention today.
Thanks, Dr. Barron. I'm thrilled to be here with you and really delighted to present our research. As Dr. Barron teed up, and we can go to the next slide, this research is supported by two distinct surveys. We conducted a survey with the general public, asking 2,000 adults who represent the United States with oversamples by race and ethnicity about their opinions on trust in the healthcare system. And then a parallel survey of physicians to a non-probability sample of 600 physicians earlier this year. Going to the next slide. We'll start by looking at the high-level findings on trust and where physicians and the public say that they are right now. So on the physician side, we see significant differences between physicians' trust in one another, as well as in nurses. So high levels of trust within the clinical staff, somewhat lower levels of trust between physicians and the healthcare organizations for which they work, and the leaders and executives of those organizations. On the public side, again, we see high levels of trust from patients with their clinicians. 84% of patients have high levels of trust in doctors, 85% in nurses, and then we see a fairly significant drop-off when asking about trust in other aspects of the healthcare system, including only 64% indicating high levels of trust in the healthcare system as a whole. On the next slide, we can see that when we ask specifically about people's trust in their own primary physician who they see most often, 78% of patients report high levels of trust in those doctors, but we see very reliable trends and significant variation across subgroups. So levels of trust increase dramatically with age, and you see that 90% of individuals 60 and older report high levels of trust in their doctors. And a similar pattern exists with income, with trust increasing reliably as income increases. Between race and ethnicity, we see high levels of trust among whites and Asians, and statistically significantly lower levels of trust reported by Black and Hispanic patients. On the next slide, we went and asked patients who reported low levels of trust in their doctors what was causing that mistrust and what was interrupting that relationship. And 25% of folks that we asked said, my doctor spends too little time with me. And the next most common responses were that their doctor doesn't know them or they don't feel that their doctor listens to them, with 14% of non-trusting patients reporting those to be the drivers of their mistrust. Moving to the next slide. We do, when we ask physicians, recognize that doctors understand how trust-building behaviors can contribute to good relationships with their patients, and particularly when we ask about time, 98% of doctors say that they understand that spending an appropriate amount of time is very important to building trust with their patients. Unfortunately, we know that that doesn't always happen or isn't always perceived by patients, and only 77% of patients asked say that their doctor spends an appropriate amount of time with them. Going to the next slide. Those differences in perceptions between physicians and their patients persist across many measures in our study. And so here are a few more. We see that while patients and physicians both believe that the other is honest with them, physicians are much more likely to say that their patients trust them. Almost all physicians say that. Only 83% of patients say that their doctor trusts what they say. And the next slide is going to give you a sense of why questions like this are so important for building trust. So on this slide, you can see the difference between patients that report high levels of trust in the healthcare system, that's those in the dark orange bars, and patients that report low levels of trust in the healthcare system, that's the light orange bars. And what you see here is that patients with high levels of trust are much more likely to report that their physician trusts what they say, that their physician spends time with them, and that their physician cares about them. So we begin to see the important link between these behaviors that physicians can perform and sentiments that they can build with their patients and how their patients feel about the healthcare system as a whole. So as we go to the next slide, I'm going to pass it over to my colleague, Krista, to tell you a little bit about how some of those levels of trust have changed during the pandemic.
Thanks, Caroline. As we continue to look at the perspectives of consumers and physicians' trust in the United States healthcare system, we gave special focus on the impact that COVID-19 has on physicians' relationships between other physicians as well as clinicians and healthcare system employers. New research shows a significant decline in physicians' trust in leaders of healthcare systems during the COVID-19 pandemic. Nearly 1 in 3 physicians surveyed said their level of trust in the United States healthcare system and healthcare organization leadership decreased. Moving on to the next slide. This is in stark contrast to the overwhelming trust physicians have in their fellow clinicians. During the pandemic, physicians' trust in other fellow physicians and nurses increased 41% and 37% respectively, while less than 2 in 10 physicians reported increased trust in healthcare organization leadership. The pandemic created a time of immense uncertainty, and the evidence on how to treat and stay safe was changing constantly over time as we learned more about COVID-19. The United States government has served as a mouthpiece for the public health and led the large-scale response to COVID-19 pandemic. The survey found 43% of physicians reported decreased levels of trust in the government agencies like the CDC and NIH during the pandemic. There were certainly missteps throughout the past year, whether it be incomplete information or confusing messaging. And in some ways, this put physicians at odds with the healthcare system as a whole. Again, you can see here, 30% of physicians experienced a decrease in their level of trust of the healthcare system and healthcare organization leadership. In a year of unprecedented pressure on healthcare, the pandemic prompted a time for the clinical workforce to band together and address the needs of their patients. For more details, including a top line and chart pack from both the consumer and the physician surveys, those can be found on the NORC and ABIM website after today's press release. Thank you.
Thank you, Carolyn and Krista. That gives us a lot to think about and begin to act on. I'm Daniel Wolfson, and as Richard said, I'm the Executive Vice President and CEO of the ABIM Foundation. My job today is to briefly tell you about what is included in the Building Trust initiative. Our strategy is three-pronged. One, convene leaders to have conversation on the importance of trust. Two, help develop research on the evidence that trust impacts performance, done in conjunction with Academy Health. And three, identify best practices on behaviors that drive trust. Our ultimate aim is to elevate trust as an essential organizing principle for improving healthcare. We will work on 3 areas of focus: relational or organizational trust, equity in reducing systemic racism, and bolster the importance of trusting science and safeguard facts free from politics. We quickly realized that declining trust in healthcare was a real challenge, but it was also an opportunity for different stakeholders to work together, ultimately to rebuild trust. People from all parts of the ecosystem, clinicians, patients, system leaders, and others, must work together to explore ways to elevate trust in each other. Our work began with an open call for examples of what we call trust practices. And you see over 50 organizations in this slide submitted strategies or approaches for building trust between patients and physicians, physicians and their affiliated healthcare organizations, or among the clinical team. We call this group our Trust Practice Network. And in many instances, their innovations led to stronger healthcare leadership, improved transparency, greater consideration of patients' needs in the practice of medicine, and many other ideas. And I want to recognize and thank them as members of the Trust Practice Network for kickstarting this work, and I want to encourage you to join. This is a robust learning community. To further this goal, all practice network ideas have been posted to our website, buildingtrust.org. It's a great resource and it's just getting started. In addition to the Trust Practice Network, the Building Trust Network includes other activities over the years aimed at promoting trust building dialogue and best practices. We'll launch a monthly communication that shares information and resources and spreads best practices across the healthcare continuum. We will host a series of conversations to highlight how different organizations, physicians, patients, and stakeholders have cultivated trust and what lessons they can teach us. That's just a few of the things planned for the coming months. We hope you will join us on this journey. I want to transition to our panel. And to do that, I want to introduce our moderator, who is also the chair of the ABIM Foundation Board of Trustees. Jackie is a well-respected communication consultant, award-winning journalist who has extensively covered healthcare and social policy. She is moderator extraordinaire, as I call her, and I'm grateful that she agreed to be pressed into service today. Jackie?
Thank you, Daniel. Always my pleasure to be pressed into service. We are in a moment going to be talking to the essential stakeholders in any healthcare setting, the patient, the clinician, the CEO. But first, just a housekeeping note, in a few minutes, we will have time for questions from everyone in the audience. Instructions on how to do that have been chatted to you. If you're calling in via telephone, you can raise your hand to be placed in the question queue by pushing *9 on your keypad. And if you're called on to speak, please remember to unmute. How many times have we all been told that in the past year? But please remember to unmute your phone by pressing *6. And now to introduce our panelists. First, Fred Cerise is the CEO and president of Parkland Health and Hospital System in Dallas. Fred is also a colleague of mine. He sits on the Foundation Board of Trustees. Donna Cryer is the founder, the president, the CEO of the Global Liver Institute, which is a patient advocacy organization. And Dr. Neil Shah is an assistant professor of OBGYN and reproductive biology at the Harvard Medical School. He is the founding director of the Delivery Decisions Initiative at Ariadne Labs, all in Boston, of course. Welcome to you all. I hope I will be able to see you in a moment. At this time, I cannot, but I'm presuming you can hear me. I want to start our conversation with a bit of a speed round and ask you each to briefly say what struck you most about these survey findings? What surprised you, what troubled you, or even what pleased you? Donna, would you like to go first?
I'm happy to. Thank you so much, Jackie, and thank you to the ABIM and ABIM Foundation for this great work. As a patient and leader of a patient advocacy organization, these insights into the gaps in perception and the discordance in perception between patients and physicians about the quality and the amount of the time spent will be so helpful to all of our work and is really what's necessary to be able to address any challenges.
Thank you. Neil?
Thank you, Jackie, and thank you for the opportunity to represent the clinician perspective here. I think what jumps out to me most is across the data, but particularly the slide with the circle of mistrust and the various causes. It seems to be the case that the plurality of Americans don't feel fundamentally seen or heard during moments where they're counting on our system to be trustworthy. And I think that's interesting for several reasons. There's a multi-billion-dollar industry right now to fill in the gaps, simply because people don't feel seen and heard. in sort of getting people engaged on apps. I think that's interesting. I also think that it implies that trustworthiness requires more than good outcomes. There's something about the process of receiving care that is eroding trust as well.
Thanks. And Fred.
Yeah, thanks, Jackie. As the hospital administrator, 30% of physicians distrusting the health system and their leaders is certainly concerning. And you saw a higher level of trust among their colleagues and nurses, but among the systems, there was a lower level of trust. And so that's something that we obviously all need to be paying attention to. And then from the patient perspective, the stat that really grabbed my attention was that 28% of the public trust the health system to always do the right thing when they are sick or in need of care. Only 28% felt that we would always do the right thing. And I think that should concern us all as well.
Yeah, there's a lot of work to be done. And Neil, I want to dig a little deeper on what you were beginning to talk about there and ask you what your impressions are about the loss of trust among physicians, in particular this past year. I know you're in Boston at Harvard, but you're a national figure. You talk to people across the country. What's happened?
Thank you, Jackie. And I do have the opportunity to talk to clinicians across the country, and I also provided care myself during some of the toughest moments during the pandemic. And I think that a lot of my colleagues felt burnt out before the pandemic hit, not from hard work, but from moral injury and misalignment between the processes of care, as I was beginning to say, and the purpose for why we're there. And I think that the pandemic certainly exacerbated that by putting people in new situations, in some cases being redeployed, colleagues in OB/GYN in the emergency room, for instance. And I think that a lot of people, particularly that dynamic that Fred highlighted with the health system, I think a lot of clinicians felt sacrificed when they were put in positions of not having enough protective equipment. And I think that they felt blamed in many cases for a lot of the very stark inequities that we see systemically.
The snapshot that we heard from the NORC researchers, the survey took place during the pandemic. What you just described, what they discovered in their survey research, do you believe it is now baked into the system, or as we emerge from the pandemic, do we shift back to where we had been? And I'm talking about clinicians.
I think that this really accelerated a longstanding issue. And honestly, I think that is existential for the healthcare system to sort of figure out how we build trust across the various stakeholders that are represented on this panel. But I worry very much that the resource, the stable of clinicians that we have right now is very burnt out and is very distrusting of the system.
Donna Cryer, when we were talking before the event, you said something that really struck all of us on the call about one of the unintended consequences of the pandemic with a possible outcome has to do with the rise in telemedicine. Fill us in.
Yes, so telehealth has accelerated exponentially. There are so many practices that we're doing a handful, literally less than 10 telehealth visits a month. We're now doing thousands of telehealth visits a week and a month. And it's been interesting to see the shift in both physician satisfaction and perception of their patients, their understanding of the patient context of their lives, and seeing them in their homes. They can understand, oh, the patient wasn't, not adherent to the treatment plan because they, didn't believe in it, because they lied to me, but they honestly, couldn't do it. And that it's created greater understanding. On the patient side, it's greatly reduced the burden of pulling yourself together, your kids together, your mother or your father, and particularly if you have a serious or chronic illness, just getting out of bed to go to the doctor's office or the health center to have a 15-minute sometimes visit. So the entire time is spent engaged with your physician, who's often looking right at you for the first time, not at their computer. And you can bring every bottle of medicine that you have, downstairs. So you can show them the contents of your refrigerator, the amount of information that you can share, to that point of being known or feeling known, feeling seen by your physician. I think telehealth has greatly expanded that, and it's certainly something that from a policy perspective, we are advocating very strenuously to make sure that the reimbursement for those telehealth visits and the audio versions as well continue, and that Wi-Fi and broadband to reach every patient possible is something that is baked into healthcare in the future.
Neil, I just want to jump back to you quickly, and then I'll get to Fred. But Neil, with the clinicians who you speak to, are they seeing telemedicine as something that is a positive development in building a trusting relationship with their patients?
Absolutely. I think that it was amazing to see how quickly it got adopted. And I think that it will likely be sticky. I mean, there are things that you cannot do virtually. You cannot deliver babies virtually, but prenatal care had a 100-year-old model that was very, very rigid and fixed. And now there are 100 natural experiments across the country about how to do it with a combination of virtual and physical services. And I think that's very exciting.
Fred, turning to you, you were an early adapter, I think, in part because you do sit on the Foundation Board of Trustees. And I think about a year and a half ago at Parkland, you launched the Trust Challenge. You were trying to tease out best practices that might help across the entirety of your healthcare system. What motivated you to do that, one? And two, what's happened since you launched the challenge?
Yeah, well, I'd probably say Daniel motivated me to do that. Just the fact
I'm surprised by that.
right? But it is that, the foundation identified this as a critical issue we should be talking about. And, it's in everyone's mind. But the fact that they identified it and said, let's put this on the table because it's important. We know if patients are more trusting, they're going to be more engaged. And so just the idea that we can talk about it. So we started soliciting ideas at our place, and it was amazing how much people wanted to talk about it, and people wanted to bring those ideas forward. And so, we did our own version of a trust challenge, and unfortunately, it was right as the pandemic was starting, and so everything, like everything else in the world, things got delayed. But I do think it Jackie, what it's done is it's put these ideas front and center. And so when you solicit these trust building practices and frame it in those terms, it does make people think, beyond just the telehealth, beyond, okay, we have to do these visits by video or by phone, but then it makes you think, as Donna said, I'm sitting here listening to Donna and thinking, we need you to talk to our clinicians, because these are things that we think we know, but to hear it from the patient perspective and to hear what a difference it makes, I think it really will change behavior and make some of these things that we do stick and spread better.
So give me an example of one such practice, and then Dawn, I'll let you jump in after that.
So, one of the things, I'll give you two real quick ones. One was our Right Care program, where we sent clinicians out with fire and EMS, or police and EMS to deal with behavioral health crises in the field. A number of places are doing that now, and it was a real partnership between police, our social workers, the dispatch systems. But the idea was to meet community members in the field, divert from jail, divert from hospitals, put clinicians in the field to be able to de-escalate conditions and get people into care at that point. And then the other one, because Neil talked about burnout in the psychological stress that providers are under, we implemented a Sparks program, which is basically a psychological first aid for healthcare providers who were experiencing stressful situations, primarily patient interaction, something that went bad. So a series of trained peer counselors to work with staff to deal with some psychological injury that they may have had.
And the number one challenge in launching the Trust Challenge?
You know, Jack, I think it's just getting your attention on it, because once we put the idea out there, people were very interested in sharing their stories. There's a lot of good work that's going on out there, and I think putting it forward and talking about it helps people and helps people think about it and think about it in terms of building trust.
Donna, did you want to respond to what Fred said?
I did. Just briefly, as a member of the Board of Trustees of our hospital, I also wanted to think about how we, Board of Trustees, work with hospital leadership to make sure that there wasn't the breakdown with our physicians and our staff during this pandemic, that there was clear and frequent communication that was fact-based, sharing the science and knowing that the decision-making was based on that science, having bi-directional communication and collaborative decision-making, and then making sure there's also transparency into how quickly from the Board of Trustees we shifted the budget in response to what the physicians and the other hospital staff were telling us they needed, whether it was PPE or time off or even changing the parking or other things to enable them to spend the hours that they were spending at the hospital. And so I think that building trust within the organization from the board level and carried through was really important during the pandemic, and I hope it will make us a stronger, more resilient organization afterwards.
Neil, when we've talked with you about trust, you also talk about trustworthiness. In your view, are they different concepts? And if so, how? And how is it relevant to the survey results?
In my conception of it, the difference is who the burden is placed on. It is not the job of the people that health systems serve to be more trusting. It is the job of the health system to be more trustworthy. And when we really think of it as a systems issue, I think what it allows us to do is think about trustworthiness as more than a virtue. Of course, it is a virtue, but it's also an output of a system that's either working or not working. And I think really just as Fred said, this framing around trust or trustworthiness, once you put it out there, people can see how the work that they're doing is either building towards that or not. And I think that's part of what's so powerful about adopting this initiative.
So a question for all three of you, and that is, how do you persuade your peers, your colleagues, that trust is something that is worth their time and attention? Because I can imagine that some people in the healthcare system would do a little eye rolling, think it's a little squishy, that there's not a lot of time to devote to something that everyone in this group views as essential. So what is the pitch that you make? Fred, what do you do to get other CEOs at other large healthcare systems interested in what you've done?
Well, Jackie, I guess we look at it from a couple of, like, an internal and an external perspective. And, internally, as I described, we started talking about it and started sharing ideas and describing practices. And when we put the invitation out there, people wanted to share their stories. And so it started a conversation. When we looked as we look externally to the community, I think that's a matter of kind of being present and showing up and being consistent. And as Neil said, being trustworthy. And that means doing all those things. And so, at the onset of the pandemic, when so many, we had this tension. Think about the vaccine distribution. We had this tension of going fast and getting everything out there, with the reality that we knew that the traditionally underserved communities were going to be left behind initially, right? And that's in fact what has played out across the country. And so one of the things we did was acknowledge up front that was going to play out. And so we use our prior experience with our community health needs assessment and our understanding of what parts of town were going to be more challenged. And then we targeted our efforts in those areas. We targeted our messaging, our media messaging in those areas. And that's where we put our pop-up vaccine clinics, and we did extra special things to make sure registrants were coming from those areas. And so our statistics didn't mirror the county stats or the national stats, but it's a matter of being intentional about it and thinking about it, because it you know, I don't think you can just turn it on. You know what I mean? It has to be something that you're doing every day.
Like trust, it has to be authentic, an authentic effort. Neil?
Well, I'm glad Donna is going last because I think her perspective on this matters most in terms of the people that we're trying to serve. But I think in terms of the pitch, one of the things I like to keep in mind is that a bad system will beat a good person every time. And that way of thinking has been so important to the patient safety movement. It's equally important in the drive to improve equity in our healthcare system. And I think if we adopt the same frame in terms of trustworthiness, we can move out of the sort of defensive posture that clinicians often take when we're thinking about it purely in moral terms and think about as a system, what can we do? And the very same coordination, continuity issues that we've been working on for a long time, if we put them in the trust frame, I think it gives us a better true north.
Thank you. Donna?
I think the name of this initiative, Building Trust, is so important because trust is built. It isn't simply awarded or conferred on the basis of authority, certainly not in the year 2021. And so I'm very involved as the head of the Global Liver Institute in working with our physicians to make sure that they are prepared and receptive to meet the needs of our patients with liver conditions. An example of that is in fatty liver disease and NASH. And people often ask, you know, why aren't we didn't start with patient education? I said we needed to start with the physician education so that patients weren't walking into offices for doctors who didn't understand the condition or weren't knowledgeable about it and sent them away discouraged or frustrated, because we recognize that frustration and that lack of trust there that it happened in that moment could take years to rebuild effort, if ever. And so our focus has been at the beginning to work with physicians so they were could be as successful as possible in building a long-term relationship with their patients. And so I think that type of approach, really emphasizing trust building programmatically as an organization and keeping it front of mind is so important. And I think that's why the information and insights in this initiative and all the ongoing work will be so important. And as a patient and who actively seeks care every day and a leader of a patient advocacy organization, looks so forward to working with the foundation.
We're going to open this up to our audience, and as we do, we're going to be bringing in our other speakers, Caroline, Krista, Rich, and Daniel. They are all here to answer your questions. We have gotten some questions about trust in institutions, which we know has been eroding for years. Can stronger relationships between patients and clinicians actually improve trust in the healthcare systems? It seems that people separate individuals from the organizations in assessing trust. Good question. Neil, you want to go for that one?
I would certainly hope so. And I think, you know, part of having the ABIM Foundation be the steward of this is that we can really think of this in terms of professionalism, competency, skills, rather than things that we assume, like, you know, people that go to medical school or nursing school are automatically empathetic or trustworthy. So I certainly hope that that'll be the case.
I would say that it only takes it so far, because physicians can only be as effective as the systems in which they work. And so one of the questions I ask so frequently of my own physicians, since I am on the board, or of the physicians that we work with in hepatology and gastroenterology is, you know, what do you need? What are the barriers to delivering the care that you want to deliver for your patients? And that's what we as an advocacy organization work to remove those barriers.
Fred, this next question I think is best answered by you. Do you think that hospital mergers and acquisitions have contributed to the decline in the trust of healthcare systems and leaders? Do people still feel their local hospital is connected to their community?
That's a great question. I mean, you know, my gut reaction is the further you get away from local, the more likely you are to erode trust. We know that the mergers and acquisitions, that has certainly contributed to increased costs. You hear the concern of patients in the NORC data on costs, where they think that hospital systems put profits above their healthcare. And so I think anything that leads in that direction, that sort of pushes us more, it is a business, but the more it feels like we're existing for business purposes and not healthcare purposes, is going to erode more trust.
I want to bring Rich Barron into this. And Rich, if you can take that question on, it feels like it's something that you've probably been thinking about.
The question, Ron Wyatt's question?
That hospital mergers and acquisitions have contributed to the decline in the trust of healthcare.
Yeah, I mean, I think that, as Fred said, the clarity with which institutions position themselves, present themselves, and the legitimacy with which they present themselves as community servants, it's possible to do that with a variety of structures. At the point at which you do a merger, you do an acquisition where your explicit announced goal is increased market share or negotiating leverage with payers, that is something that is not likely to inspire trust. It says that the people in the C-suite are focused on growing market share, or they're focused on improving leverage, or they're, and so I think it's not so much that it's happening because sometimes it can happen in a way that can serve a community better. It's the way that it seems to be happening frequently, not with that goal in mind, but some other set of goals in mind.
We have a question from Tricia Barrett from Bayer for the NORC researchers, Caroline and Krista. To what extent are you concerned about the low response rate from Black physicians, only 2% of survey respondents, or is that representative of the diversity in the workforce?
Yeah, approximately 5% of the active physician workforce is Black. So that percentage is not as low as you might initially think. Although I will note that we did not explicitly quota the physician sample on the basis of race and ethnicity. We quoted more based on specialty and location of practice. But that I think ties into our broader discussion about trust, which is we have a workforce that currently does not mirror that of the nation, and that is likely to be an area for further attention.
All right, thank you. We've received a question about distrust of insurance companies and how this has intensified conflict between clinicians and payors. The degree with which hospitals and health systems support their providers will go far in rebuilding trust for healthcare organizational leaders by clinicians. What are the panelists' thoughts? Fred, I think you're up on this one.
So Jackie, let me make sure I understand. There was a lot there. Can help me out? Give me the question in the concise. Like, is it about?
I have a thought on it.
The degree that insurance companies lead to distrust.
This is about payment and billing, which is focused on insurance companies, but how does that leak into the relationship between clinicians and payers?
Yeah.
I could take this one too.
Yeah.
Daniel, you want to do it?
Sure. I'm a person that spent 23 years on the health insurance side. And what you see a lot with health plans and providers is a lot of finger pointing and blaming others and not building good relationships. But there's a lot of good examples of people making good relationships between health plans and health providers. One example is the University of Michigan and Blue Cross Blue Shield of Michigan, where Blue Cross Blue Shield of Michigan put up resources for quality improvement, put all the health systems on notice that they'd be accountable for performance. And University of Michigan became the kind of the center point for all activities. And it was just an excellent example of collaboration between health plans and providers in pursuit of a goal of better quality of care. So You know, this effort is about finding good practices and best practices, and that's one good one. And I think you'll see a lot of, if you were to explore, a lot of positive things that happen between health plans and and providers. And we have to just stop finger pointing and find solutions where we can work together in common mission and common purpose.
We have a question. I'm particularly interested in how to address trust in science in today's politicized environment. What are some of the first steps you think are needed in this area? Rich Barron.
Yeah, that is a great question, because I think that we really are living in a world in which facts themselves, the whole existence of facts, is in dispute. How do we explain the number of people in the country who are just not interested in a COVID vaccine, or who are turning away from pretty established science? And we can imagine that would be some people, but the scale on which we're seeing that suggests a major politicization of knowledge. I think one of the most important things, and we're hoping this initiative will advance this conversation, is the scientists themselves have to stop believing that if they just put more data out there, if they just put more science out there, that will change minds. I think we really need another strategy, and we need to understand the way in which it's relationships that shape the way people experience information. And those relationships get created in a variety of settings. And Ron Wyatt put in the question, shouldn't you just go to the community and apologize and be clear about your intention? I think there's a lot to be said for apology as a strategy and clarity as a strategy. But I think many people in healthcare would be saying, well, apologize for what? Why would I need to do that? The idea that you become aware that there are people who believe they have been injured by what you have done, that you have an opportunity to honestly reflect on how they might have a reason to believe that, and then try to engage with that. And the idea that that kind of thinking and that kind of work at the institutional level is what we're going to need to do to get past this, I think that has everything to do with how we try to get more respect for science, is if people see science as connected to themselves and open to their worlds in a way that they don't right now. Many people don't.
Neil Shaw, do you want to jump in on what Rich just was talking about and how this issue of disinformation comes into a clinical setting and what you do with it?
Yeah, I mean, whenever Rich speaks, I have a parallel dialogue in my mind, so I'd love to jump in. But I guess my thought is that the process by which people are distrusting science in some ways even connects to Dr. Aurora's question in the chat about time. But I think one of the things that we're limited by in upholding science or even clinical process is that people don't see into it. People need to be able to understand how you've arrived at your result. And I think part of the challenge that we've been seeing at with science generally, or disinformation, but particularly during the pandemic, is just how quickly our understanding of the interpretation of the facts has been evolving. I mean, as a clinician on the front lines, I will tell you that even down to this week, when people asked me what our hospital visitation protocol was, or the protocol for, time of discharge versus time of visitation, like I don't know, it changes all the time. And that applies to everything, whether it's a scientific fact or a clinical process or even a health system level policy. People really need to understand the process and how we've arrived at that conclusion. And I think that's on us.
Thank you. Caroline, I want to turn to you or Krista on this next question. This is something you touched on in your briefing, but the question wants you to go a little deeper. What did the survey reveal on the relationship between race and trust?
Yeah, so we teed this up at a high level, and you saw that there were significant differences in trust by race and ethnicity. And today's research is really the first phase. So I'm going to preview the second phase of our research is going to dive in to the connection between race, ethnicity, and trust much more fully, looking specifically at how incidents of discrimination within the healthcare system, both for physicians and for patients, impact their sense of trust and well-being. And then further, how physicians believe that we can and will begin to improve racial inequities within the healthcare system. So stay tuned, more results to come next month.
All right. Anne Grenier with the Primary Care Collaborative has a question for Rich and other panelists if you want to jump in, because this is an important and broadly worded question. In terms of the healthcare system, a key locus of care coordination and integration is primary care. The primary care platform, as measured by primary care spend, has been declining for a decade, it's been made worse by COVID. What connection do you see between the Trust Initiative and primary care?
I think that the pandemic has really focused a lot of attention on primary care, and primary care can be critical in rebuilding trust in healthcare. Partly, we know that face-to-face encounters are a huge opportunity to build trust. They're also a huge opportunity to generate mistrust. And some of the things that we hope will come out of this work together will be more standard practices in primary care that will build trust. But primary care has built into it continuity. It's patient-centered in a way that that procedure-based care is more transactional. And so the continuity and patient-centeredness of primary care generate a foundation of trust. And I think the rest of the health system has a lot to learn from primary care. But as Anne points out, been pretty stressed in the pandemic, and the recent National Academy of Science report on primary care is worth a look. There are some real recommendations for how to fix that.
Fred and Neil, quick comments, and then we're going to turn it back over to Daniel.
Yeah, I would just add, you know, the comment about primary care getting eroded further, you know, and that is, that's a natural thing as we place so much emphasis on, you know, the acute side and on specialty care. And so I think we have to be intentional. The payers have to be intentional. Health systems have to be intentional. I know we have to sort of carve that out and, you know, specifically identify it and support it. Otherwise, you know, sort of the momentum is to continue to fund sort of the higher and higher and higher tech in smaller areas.
I would just add, you know, as an OB/GYN, I sit sort of between primary care as I think about it, because I have continuity with my patients, it's them a lot, and I do surgeries. And I think the value that I'd really want to uplift that really spans all specialties is that when we're thinking about trust, whether it's around information or science or a clinical process, there's an expertise that we have from our technical knowledge as clinicians, and then there's an expertise that the people that we're serving have in their own lived and embodied experience. And I think there's a real opportunity to see those as complements, really across the spectrum of care.
Great final word. Thank you, Neil. Thank you, Donna. Thank you, Fred. Appreciate it so much. And now it's back to Daniel. You have the stage.
Thank you, Jackie. That was such a good panel. I really thought you guys were wonderful and wonderful compliments to each other. So thank you. Thank you all for attending. Carolyn and Krista, thank you, and thank everybody from attending. As you probably know, ABIM Foundation is all about collaboration and partnership. So we're here today to openly invite you to connect to this initiative. It is really going to be the communities that owns this initiative. And we can't do anything as a small foundation without collaborating, without partnering. And we want to partner with research. We want to partner with collecting examples and really understanding what drives trust. So please contact me at dwolfsonabim.org and let's have a conversation. Let's talk about submitting practices. Let's talk about joining our learning community. We're very excited and very dedicated. This is not a year project. This is a multi-year project, and we want to grow the community in the next 2, 3, 4 years and really arrive at a point where trust is an essential component of healthcare, and it has a tremendous impact on the performance of the healthcare system and be the healthcare system that we all want and desire. Thank you so much. Have a great day. Be safe.